Well, Celia gave me this title, Has Advanced Imaging Changed the Clinical Management of Proximal Suspensory Desmitis? And I thought, how often do I use advanced imaging? I really like ultrasonography, and I think ultrasonography is pretty reliable. But then I thought, well, there is the occasional case when I don't think the ultrasonographic findings fully explain the severity of the lameness, and therefore I may choose to do scintigraphy, which may tell me we've got osseous involvement as well, or I may, if the client has got more money, choose to do MRI, which can also tell me that I've got osseous involvement. But does that change how I manage the case? It does tell me, I think, that this horse is probably going to take longer, but does it change anything else that I do or that other people do? And then I thought, well, we can't just think that proximal palmar metacarpal region pain equals proximal suspensory desmitis, because it doesn't. Nor can we think that our blocks are specific, because they're not. So this was the theme, why it is necessary to image not only the proximal metacarpal region, and I'm going to focus on the forelimb, but also the carpal region if local anesthetic solution in blocking the proximal palmar metacarpal region has rendered the horse substantially improved. I want to talk a little bit about some normal findings on MRI which can be confused with lesions. I want to review some of the published data on the different types of lesions that different centres have identified in horses with proximal palmar metacarpal region pain, and then finish by talking about a questionnaire survey asking practitioners from around the world, has advanced diagnostic imaging changed their management of proximal suspensory desmitis? So why is it important to assess both the carpus and proximal metacarpal regions? This was an endurance horse with an acute onset severe lameness, which was completely abolished by palmar metacarpal nerve blocks at subcarpal level. Subsequently, on a separate occasion, intra-articular analgesia of the middle carpal joint produced improvement, but not complete resolution of the lameness. Ultrasonographically, there was nothing abnormal to see, but radiographically, we always include the carpus, and we often will include skyline views of the carpus if necessary. And here we can see we've got increased opacity of the radial facet of the third carpal bone and a parasagittal fracture, which was confirmed surgically. This was treated by internal fixation, and there was rupture of the medial palmar intercarpal ligament, identified arthroscopically. So this shows very nicely clinically that our nerve blocks can be misleading. And we have reinforced this using radiodense contrast studies when we have shown that if we inject 2 ml of a radiodense contrast medium, we can get spread into the middle carpal and carpometacarpal joints. So we have the potential for inadvertent injection of the distal outpouching of the carpometacarpal and middle carpal joint capsule. We know that if we use the medial approach to the lateral palmar nerve, that we get spread not only around up the median nerve and around the deep branch of the ulnar nerve. So this block at this level here, which will desensitize the proximal palmar metacarpal region, also has the potential to desensitize, anesthetize the caudodistal aspect of the antebrachium and the palmar aspect of the carpus as well. So it's not specific. Our third option is to inject the lateral palmar nerve through the ligament which runs from the accessory carpal bone to the head of the fourth metacarpal bone, as we have done here with radiodense contrast medium. But we have the potential to inject into the carpal sheath. In our study, we had injection into the carpal sheath in 12.5%. In a previous cadaver study, there were 68% of horses which were injected into the carpal sheath, which could produce a false negative response to your block. So I think if you have a positive response to palmar metacarpal analgesia, whichever way you choose to do it, you have to think, I may be dealing with carpal disease in general terms, or proximal palmar metacarpal disease. If we want to think about using MRI as our advanced imaging technique, it's really important that we appreciate some normal variance. We conceive that ligaments and tendons should have a uniform low signal intensity, but that is not the case for the accessory ligament of the deep digital flexor tendon. In many normal specimens, we will see areas of increased signal intensity or greater signal intensity than the rest of the ligament. And this is perfectly normal. So to see increased signal intensity in an accessory ligament of the deep digital flexor tendon on an MRI does not equate with pathology unless perhaps the ligament is also enlarged. What's the reason for this? The reason for this is that we don't have straight parallel aligned fibers as we do in the deep digital flexor tendon. We have fibers that go in different directions, all sorts of different directions. So we have the potential for a magic angle effect. It's also important that we realize that there are attachments between the proximal aspect of the suspensory ligament and the axial aspect of the fourth metacarpal bone. So this band of tissue here is not an adhesion. That is a normal anatomical structure. And it's really important, if we're going to be using advanced imaging, that we are aware of what is normal. So let's now look at some of the studies that have investigated horses with proximal parametacarpal region pain. And the first one is a study from here, Sarah Powell's study, when they looked at standing magnetic resonance imaging, that's using a low Tesla magnet, 0.27 standing MRI. And they're looking at racehorses. And they're looking at racehorses which have had a positive response to subcarpal analgesia. Not all of them were sound, but they all showed substantial improvement following subcarpal analgesia. And they had all had normal or equivocal findings on both radiography and ultrasonography. And all of these horses turned out to have primary bone pathology involving the third metacarpal bone, with various patterns of changes in signal intensity in the proximal palmar medial aspect of the third metacarpal bone, with some having small areas of increased signal intensity in the palmar cortex of the bone, consistent with a fracture. So they were all medially based, and they were interpreted as stress-related bone injury. So we can see this is a T1 weighted image, a T2 weighted image, and a stir image, and we've got reduced signal intensity here, increased signal intensity here, with a line of reduced signal intensity reflecting a water-fat cancellation artifact, and generalized increase in signal intensity. So how were these horses managed? They were treated by box rest until they were free from lameness, which was between 2 and 4 weeks, and then started walking exercise. One of the 8 horses had restricted turnout for 3 months. The time taken to return to fast cantering ranged between 4 and 23 weeks, and 7 of the 8 horses raced between 7 and 35 weeks of diagnosis. So purely conservative management. 3 of the horses underwent follow-up radiography, and 1 horse underwent follow-up MRI, and there was evidence of endosteal new bone, suggestive of a response to fracture. 3 of the 8 horses did have recurrent subcarpal pain, 2, 5, and 11 months respectively after the initial diagnosis, and these horses were treated by extracorporeal shockwave therapy, N=1, and medication of the middle carpal joint, N=2. And these horses did return to training, but it was not documented whether or not they raced. So my question is this condition in these young thoroughbreds any different from the palmar cortical fatigue fractures that we can sometimes diagnose using radiography? These are in the proximal palmar medial aspect of the third metacarpal bone, so an identical location and often associated with very, very similar changes on MRI. We reported on 55 horses, these were mostly sports horses, with these palmar cortical fatigue fractures, which we can see an obvious one here, which are associated with intense focal increased radiopharmaceutical uptake. Some of the horses are bilaterally lame, and if they're bilaterally lame, they will have bilateral increased radiopharmaceutical uptake. This horse was bilaterally lame, lamer on the right forelimb compared with the left. Greater radiopharmaceutical uptake intensity in the right forelimb compared with the left. So of our 55 horses, 26 underwent scintigraphy, and 82% had increased radiopharmaceutical uptake in the proximal palmar aspect of the third metacarpal bone, and the remaining 18% had it slightly further distally. And it ranged from intense in 39%, 17% moderate, and 44% mild. Whereas in the non-lame limbs, we only had 14% which had mild increased radiopharmaceutical uptake, and the majority, it was normal radiopharmaceutical uptake. So how did we treat these horses? We also treated them just by box rest and controlled walking exercise alone. And we had follow-up on 47 of the 55 horses, 98% of which returned to full athletic function for a minimum of 1 year post-treatment. The duration of rest varied between 1.5 and 7 months, with both a mean and a median of 3 months. So these primary stress-related bone injuries get better, whatever we do effectively, as long as we rest them. Matt Brocken, who was at Washington State University when he carried out this work, reported on magnetic resonance imaging features of proximal metacarpal and metatarsal region pain. And they had 29 horses which presented with forelimb lameness between 2000 and 2005. And these horses that were included in the study showed at least a 60% improvement in their baseline lameness after subcarpal analgesia. Now, 60% I think is unsatisfactory personally. I would most definitely be doing additional nerve blocks if it was my case, because I wouldn't feel comfortable that I was identifying the right source of pain based on only 60% improvement. And they used 12 ml of mepivacaine for their local flooding of the area, which I think is an extraordinary amount. And they waited up to 30 minutes to evaluate their responses, which also I think is a little extraordinary. I would find this a very non-specific approach. There were no significant radiological findings in the horses which underwent radiography. The ultrasonography was reliant on referring veterinarians' images, which were not seen by the people doing the study. The findings were said to be either equivocal or negative. And these horses all underwent high-field MRI using a 1 Tesla magnet under general anesthesia. And of their 29 horses with forelimb lameness, they diagnosed proximal suspensory desmitis in 10. And this is such a lesion here. We can see this increased signal intensity on the dorsal border of the suspensory ligament. Desmitis of the accessory ligament of the deep digital flexor tendon in 16. A combination of injuries of the deep digital flexor tendon and its accessory ligament in 2. And primary osseous injury in the palmaroproximal aspect of the third metacarpal bone in 1. So very different population of horses to that described by Sarah Powell. So how did they manage these horses? Of those horses with proximal suspensory desmitis, of which there were 10, the majority were treated by box rest and walking exercise for 2 months, small paddock turnout, with a total rest period of 6 months. And 8 of the 9 returned to full function. 1 horse was treated by suspensory ligament splitting and also returned to full function. My question is, do these horses differ from those that we diagnose using ultrasonography? If I diagnose primary proximal suspensory desmitis as an acute injury or first-time injury, rather than something that has been recurrent several times over, I will always say to the client, irrespective of the severity of the problem, that in my population, 90% of the horses return to full athletic function just by box rest and controlled walking exercise. They had 16 horses with desmitis of the accessory ligament of the deep digital flexor tendon. So we can see that this part of the check ligament is enlarged and has diffuse increased signal intensity. Their numbers are very confusing in the paper, I'm afraid. I'm not sure whether there were 13 or 8 which had acute mild lesions. Some of the horses were treated by desmotomy of the check ligament. I'm not sure whether it was 3 or 8, despite reading this paper numerous times. Anyway, overall, 50% of horses returned to their previous level of function. And of the horses treated surgically, 3 out of 8, that's 38%, returned to full athletic function. How does this compare with previously published data based on lesions identified using ultrasonography? My initial study showed 76% of 27 horses returned to full function. McDermott in 1994 had 43% returning to full athletic function. And Vandenbelt from a Dutch study showed 18% returning to full athletic function. These were mostly warm bloods, and whether or not warm bloods themselves have a poorer prognosis is, I think, remains unknown. My question is, are these horses more likely to have had more severe injuries associated with obvious swelling, which would have highlighted the fact that there was a check ligament injury present, compared with the Washington State study? Because presumably they didn't have palpable abnormalities, although that also, unfortunately, cannot be determined from the paper. So are we comparing like with like? And are there any differences in the anatomical locations of the lesions? When you look carefully, 12 of the 16 horses in the Brocken study had lesions which were between 1 and 4 centimeters distal to the carpometacarpal joint, which is pretty high, and not the more common location, which is more commonly in the middle 1/3 of the metacarpal region. And these cases perhaps are more similar to those that we have previously described using ultrasonography, with lesions which are very much restricted to the origin of the ligament on the palmar aspect of the third carpal bone, extending distally down into the proximal metacarpal region. And unquestionably, those horses, I think, do less well than the horses with the much more obvious lesions further distally. There's even more confusion, because from the same institution, there was a study describing the results of desmotomy of the check ligament in the forelimb of 24 horses over a longer time period than the previous study. And we had 9 lame horses, 1 acute and 2 chronic, 7 horses diagnosed using MRI, 4 horses had diffuse enlargement and diffuse regions of increased signal intensity on the MR images, but 3 horses only had focal areas of increased signal intensity and no enlargement. And I think, were those genuine lesions, or were they related to what I've already described as the normal, relatively greater signal intensity in the check ligament in some areas? So in this report, they had 5 of 8 horses, 62% returning to full athletic function, compared with the 3 of the 8 horses described by Brocken. And the question is, are they the same horses? Because the study periods overlapped. So it's all very, very confusing. So the next study I want to describe is a study that we did retrospectively, looking at the MRI findings in the carpus and proximal metacarpal regions of 50 horses. And these were horses either which had their lameness substantially improved, and by substantially I would say 90% or more, by perineal analgesia of the palmar-metacarpal nerves, or were sound after median and ulnar nerve blocks. Some of them only had ulnar nerve blocks alone. So we had 30 that were sound after perineal analgesia of the palmar-metacarpal nerves or the lateral palmar nerve, and 20 who required either ulnar or median and ulnar blocks to get them completely sound. And all of these horses underwent comprehensive radiographic examination, including skyline views of the carpus, and comprehensive ultrasonographic evaluations of the palmar aspect of the carpus and metacarpal region. The majority of horses were examined using low-field MRI, and only a small number had high-field MRI. So of the 50 horses, 41 were lame unilaterally, and 9 were bilaterally lame. The duration of lameness varied between 1 week and 2 years, with a mean of 3.4 months and a median of 1.5 months. And the horses ranged between young thoroughbred racehorses of 2 years of age up to horses of 7 years of age. So the median and mean were 7 and 6 years respectively. So we had 24 thoroughbreds, 17 warm bloods, and 9 mixed breeds. 20 of the horses were used for racing, 8 were used for show jumping, 8 were used for dressage, 5 for eventing, 4 for endurance, and 5 were general purpose horses, which includes horses used for unaffiliated level competition. And often on the MR images, we would find several abnormalities which could potentially contribute to pain and lameness. And the primary lesions were determined by the response to local analgesia and the work discipline. So of our 50 horses, we had only 4 with proximal suspensory desmitis. So it was a low yield for identifying proximal suspensory desmitis. We had no horses which had injuries of the accessory ligament of the deep digital flexor tendon. The majority of the horses had osseous pathology. Osseous pathology, particularly in the medial aspect of the carpal bones and the proximal metacarpal region, which was seen in 29 horses. And then we had 9 horses which had evidence of syndesmopathy between the second and third metacarpal bones. So this was a horse which was a bilaterally lame horse. It underwent both scintigraphy and MRI. Multifocal increased radiopharmaceutical uptake that we can see in the carpus and proximal metacarpal region. An incidental radiological finding, this osseous cyst-like lesion in the ulnar carpal bone and a fragment. These are rarely of any clinical significance. But on MRI, we see evidence of primary bone pathology. We see evidence of reduced signal intensity in the radial facet of the third carpal bone and in the proximal medial aspect of the third metacarpal bone and the second metacarpal bone. And this was another horse. This was a horse which did have minor radiological changes. There was a very ill-defined osseous cyst-like lesion surrounded by an area of increased opacity in the second carpal bone. And here on MRI, we can see that we've got increased signal intensity in the interosseous ligament between the second and third carpal bones. So a very different spectrum of injuries compared to those described by both Powell, which was a study population of young thoroughbreds, and those of Brocken et al., which were primary soft tissue lesions. Here we found that osseous lesions predominated. Myra Barrett from Colorado State University was published recently the findings of MRI in the proximal metacarpal region of quarterhorses used for cutting. And this was a retrospective analysis of 32 horses. All of these horses were substantially improved by subcarpal analgesia and had had equivocal findings on radiography and ultrasonography. They underwent high-field MRI under general anesthesia using either a 1 Tesla magnet or a 3 Tesla magnet. And they found predominant lesions in the suspensory ligament. 70% had enlargement of the suspensory ligament. 25% had alteration of the fat, muscle, or ligament architecture of the suspensory ligament. 68% had dorsal border irregularity. 57% had alteration in the signal intensity within the tissues of the suspensory ligament. And 95% had alterations in the signal intensity in the proximal palmar aspect of the third metacarpal bone. So although 70% had lesions of the suspensory ligament, a lot of which had concurrent osseous pathology, there was an additional 25% which appeared to have primary osseous pathology at the entheseous with the suspensory ligament. And they graded the lesions based on predefined criteria as either mild, moderate, and severe, because they wanted to look to see whether or not the severity of the lesion influenced return to work. So the treatments were not standardized among horses, and some horses received all of these treatments. Most horses received 2 or more of these treatments. So the treatments included extracorporeal shockwave therapy, repeated several times, systemic and regional perfusion of toluidronate, periligamentous platelet-rich plasma or triamcinolone, and a rest period of approximately 6 months. The exercise during that rest period was not well defined. And the follow-up was based on show records or contact with the owner. So of the 30 horses for which follow-up was available, 22, that's 73%, returned to competition. But the rules of competition are that medication is permitted. So not all of these horses that returned to competition were non-lame horses. The duration that it took to return to competition was variable. 14 returned within 6 months and 8 within 12 months. They found no significant relationship between the severity of the lesions, the presence or absence of bone lesions or just soft tissue lesions, and either return to competition or time to return to competition. So irrespective of the diagnosis, it seemed, some got better and some didn't. And it's impossible to tease out which treatments were successful because the horses had so many treatments. Whether or not it was the rest or whether any of the other treatments were influential, I think remains open to question. So I'm going back to my question, does advanced imaging influence our management of horses with proximal suspensory desmitis? And I thought that I don't have sufficient personal experience to answer this question. So I sent a survey, a questionnaire survey, to 52 sports horse veterinarians who I thought had access to advanced diagnostic imaging, either in their own clinic or I knew that they referred regularly to clinics. And these were all people whose clinical judgment I respected and who I thought would also give me honest answers. So my practitioners, and some were in institutions, others were in private practice, were based either in Europe, Australia, the USA or the United Arab Emirates. And I had a 42.3% response rate, which I thought was a bit disappointing, but it's better than many questionnaire surveys. So one of the first questions I wanted to know was how frequently are people using advanced diagnostic imaging? Because I think, well, I don't use it very often in proximal palmar metacarpal region pain. So what proportion of horses in your care in which pain is localized to the proximal palmar aspect of the metacarpus undergo either CT or MRI in addition to radiography and ultrasonography? And of our respondents, 68% said less than 10% of the horses would undergo advanced imaging. And I was quite surprised that 32% said between more than 10% and less than 25%, because I thought that was a pretty high, a very high proportion. So then I asked a series of questions about different clinical scenarios. So the first being, if you have acute forelimb proximal suspensory desmitis of less than 1 month's duration with no associated osseous pathology. And I gave a very comprehensive list of various treatment options and also a box for other, and please fill in other to tell me what treatments they were using. So 59% would treat these horses by rest and controlled exercise alone. I'm one of that 59%. 36% would use rest and controlled exercise and either extracorporeal shockwave therapy or radial pressure wave therapy. Included in this were 6 individuals who would also use platelet-rich plasma. And then we had a much smaller percentage of about 5% who used rest and controlled exercise plus class 4 laser treatment. The duration of controlled exercise was very variable, between 2 and 12 months, with a median of 3 months. And I would always say to an owner with acute proximal suspensory desmitis, 3 months is the time of period that I would expect we would have to rest this horse, plus controlled walking exercise. So my final question was, what percentage of your horses would you expect to return to full athletic function? And between 50 and 75%, we had 18.2 of the respondents. Between 75 and 90%, we had 72%. And more than 90%, only 9.1%. And I was surprised about that, because I think acute proximal suspensory desmitis, treated appropriately, has a good prognosis without osseous pathology. So I'm in this more than 90% category. The next question related to chronic proximal suspensory desmitis with no associated osseous pathology. So chronic being more than one month duration, or a horse had had a recurrent injury, a previous acute injury, but had had recurrence. So the percentage using just rest and controlled exercise alone was substantially less, 13.6, plus one individual who would treat locally with iodine. Much higher use, now 73% of horses being treated with either extracorporeal shockwave therapy or radial pressure wave therapy. A slight increase in the number of horses treated by class 4 laser, going up to 9% of our respondents. And a small proportion of the respondents said that they would use neurectomy. So that was 4.6% in the first instance, but 6 individuals suggested that if the problem became recurrent, they would resort to neurectomy. So the duration of controlled exercise was very similar range, but double the time from the median value. So a median value of 6 months. What about success of treatment? So more than 90%, we've still got 9.1%. Between 70 and 90%, we've got less than before, only 4.6%. So we've got the majority, 77% of the respondents, saying between 50 and 75% of their horses are likely to return to full athletic function. But we do have about 9% of horses respondents who said that only between 25 and 50% of horses that they managed would return to full athletic function. So a wide range of experiences. The next question related to the presence of either acute or chronic proximal suspensory desmitis with the presence of entheseous new bone on the proximal palmar aspect of the third metacarpal bone. And the majority of the respondents said that they would not alter their treatment regime compared with just chronic proximal suspensory desmopathy alone. The next question related to horses which had undergone MRI and had acute proximal suspensory desmitis with concurrent endosteal reaction and extending into the trabecular bone up to about half the dorsopalmar depth of the bone, characterized by reduced signal intensity in T1 and T2 weighted images and or increased signal intensity in stir images. And now we see people introducing the use of bisphosphonates. I ask why? What are bisphosphonates going to do when we want bone to repair? Bisphosphonates are supposed to inhibit osteoclastic activity. Is that going to be a benefit? I find this rather difficult mentally to understand. But anyway, 50% of the respondents would now use bisphosphonates as part of their treatment regime. One person would use radial pressure wave therapy and a wide shoe. Some people would use bisphosphonates, PRP, and extracorporeal shockwave. That was one respondent. And bisphosphonates combined with mesenchymal stem cells by one respondent. And everybody agreed that a longer period of rest would be required. The duration of recommended rest was very variable among the respondents. 3 to 5 months by 4 people, 6 months by 5 people, 6 to 9 months for 6 people, and between 9 and 12 months for 5 people. And what was the anticipated outcome? So we've got down to 19 respondents for this. So a very good prognosis, only 5%. A moderate prognosis, between 75 and 90%, 10%. And then between a predicted success rate of between 50 and 75% of horses returning to full athletic function being the most popular by 42% of the respondents. And then less than 50% being also used by 42% of the respondents. So an agreement that this type of pathology is going to both prolong the convalescent time and reduce the prognosis compared to those horses without osseous involvement. And then the next category was a similar type of injury, but with a more chronic injury. So both proximal suspensory desmitis plus osseous pathology. And longer rest was almost universal. There was an increased use of class 4 laser, an increased suggestion of neurectomy. And the duration of rest, again, was very variable amongst the respondents, but leaning towards 9 to 12 months. And the anticipated outcome was significantly reduced. We still have one respondent who says that in their experience, they would have a good outcome. And we'll come back to that respondent later. And now we've got 55% saying the prognosis is less than 50%. And 40% of the respondents saying that their success would likely be between 50 and 75%. The next possible scenario was those horses which have proximal suspensory desmitis in association with adhesions to the 2nd, 3rd, or 4th metacarpal bones. And we had 7 respondents who would advocate surgical resection of such adhesions, 1 person advocating neurectomy, 1 person advocating internal blisters, 3 recommending the use of local corticosteroids, and 3 recommending shockwave therapy. We had only 15 respondents who claimed experience of management of these problems, and we had 20% of respondents saying they would offer a prognosis of between 50 and 75%, whereas 60% had less than 50% success rate, and that would certainly be my experience. Another scenario was combined injuries of both the suspensory ligament and the accessory ligament of the deep digital flexor tendon, which we see in a proportion of horses that we evaluate ultrasonographically and also using MRI. And we had 26% of the respondents saying they would use rest and controlled exercise alone, nearly 58% using extracorporeal shockwave therapy or radial pressure wave therapy, with 5 people also saying that they would treat specifically the check ligament, but not the suspensory ligament, with platelet-rich plasma. Nobody was using class 4 laser. Rest and controlled exercise and platelet-rich plasma was advocated by 10%, and rest and controlled exercise and mesenchymal stem cells by 1 individual, that's 5%. And again, we had a very variable duration of the total period of rest that people would recommend. And the anticipated outcome, 1 person saying greater than 90%. It's always the same person who has greater than 90%, which is very interesting. I'll tell you why in a little while. Pretty poor outcome, really, only for the rest. So we've got about 16% saying a prognosis is better than 50%, but we've got 77% saying worse than 50%. And that would certainly be my experience in horses which we've diagnosed ultrasonographically with combined lesions. Yes. I've lost a slide, I think. Have I lost a slide? Yes, I've lost, yes. Okay. Now I just want to mention very briefly the potential limitations of advanced imaging. Advanced imaging, unless perhaps you have a 3 Tesla magnet under general anesthesia, is very poor at identifying articular cartilage lesions. So this was a grade A show jumper, lame on the right forelimb only when ridden on the left rein, improved by palmar-metacarpal nerve blocks. Lameness was abolished on a subsequent occasion by intra-articular analgesia of the middle carpal joint. Nothing to see radiologically, nothing to see ultrasonographically, nothing to see on MRI. And this horse went to arthroscopy, and this is a very focal, full-thickness lesion on the proximal aspect of the second carpal bone. So MRI has limitations. I think we have to recognize that. So if we're thinking we might have cartilage pathology, MRI is going to be limited. So has advanced imaging changed the clinical management of proximal suspensory desmitis? I think that it has enabled us sometimes to get to more specific diagnoses. And the recognition of some pathological changes encourages people to use a gamut of different treatment methodologies. I think it's impossible to tell whether those treatment methodologies are in any way enhancing the recovery of those horses versus rest alone. The one person who claimed the greatest success was Dr. Carol Gillis. Dr. Carol Gillis is an American practitioner who specializes in ultrasonography and rehabilitation. And in all the questions, and Carol is somebody that I intuitively trust, I've known her for many, many years, and if she says that something is successful and she's returning horses to full athletic function and she's dealing with upper-level sports horses, not just happy hackers, I believe her. And she had a 90% success rate for all of these categories. And I've spoken to her at great length about her rehabilitation programs, and her rehabilitation programs are very tailored to individual horses. And she has huge client compliance. And I think there's probably a lesson to us there for what can be achieved just through rest and controlled exercise. I think that knowing the nature of the lesions does enable us to predict the necessity for a longer rehabilitation program than owners might otherwise accept. Because if they identify just a soft tissue injury on ultrasonography, they may not appreciate that longer than 3 months may be required. So that it may be useful from a client management perspective for buying oneself extra time. And finally, I'd like to conclude by acknowledging those practitioners who took the time to fill in my questionnaire. I'd be happy to answer any questions.